Welcome to Inflection Point. Our webinar will begin shortly. This session is being recorded and we will send a link out to everyone. Also, there will be a Q&A session after the presentation. You can enter questions in the question box at any time during the webinar. Thank you. Welcome to Inflection Point. Our webinar will begin shortly. This session is being recorded and we will send a link out to everyone. Also, there will be a Q&A session after the presentation. You can enter questions in the question box at any time during the webinar. Thank you. Welcome to Inflection Point. Our webinar will begin shortly. This session is being recorded and we will send a link out to everyone. Also, there will be a Q&A session after the presentation. You can enter questions in the question box at any time during the webinar. Thank you.
Hello, and thank you for joining Inflection Point, hosted by the Go Red for Women Venture Fund. Inflection Point explores the new frontier where science, investment, and innovation intersect to elevate health for women. Today, we're looking at the connection between women with migraine and the risk of stroke. And it's my pleasure to welcome Dr. Michelle Leppert and Madeleine Livingston. Dr. Michelle Leppert is an associate professor at Tufts Medical Center, whose research is focused on ischemic stroke in young adults. Her early work expanded Her early work examined large national databases and revealed that women under 45 experience higher stroke rates than men, and that non-traditional risk factors such as migraine, autoimmune disease, and thrombophilia play a larger role in younger individuals rather than traditional vascular risks. Her findings highlighted the significant contribution of migraine to early onset stroke and exposed key gaps in existing data sets. Dr. Leppert's ongoing work aims to collect primary clinical data to better understand causal pathways and identify novel targets for the prevention of and treatment for stroke in young adults. Madeleine Livingston is a healthcare leader with over a decade driving multi-million-dollar partnerships, research initiatives, and capital strategies across startups, corporations, nonprofits, and global forums. She's experienced in mobilizing payers, employers, and industry to fund underinvested women's health R&D and translate innovation into economic impact. She's currently the Director of Strategic Partnerships at 30 Madison, where she spends time leading go-to-market strategy for Cove, the largest virtual migraine company. Thank you both for joining us today. For our audience, you can enter questions in the Q&A box at any time. Dr. Leppert, will you start us off with a look at the connection between migraine and stroke?
Yes, I will. And thank you for having me. I'm always very excited to talk about my favorite topic, which is migraines in young women and why they lead to strokes. So I just want to give you a brief whirlwind of how I ended up in this space, which was completely unexpected. So if you know, hopefully this is not a spoiler alert for anyone, but stroke incidence has been decreasing, and largely thanks to efforts of organizations like the AHA. We're controlling a lot of vascular risk factors, and over the last few decades, we've seen a tremendous decline in the number of strokes that are occurring. However, if we zoom in the graph on the portion of strokes that are attributable to young adults, so those under 55 years old, we'll see that very contrary to what's happening in older adults, that strokes in young people are actually increasing. And this trend obviously is very disturbing and has been my primarily research interest over the last decade. So the prevailing belief about 10 years ago when I started this work was that surely strokes are increasing in young people because we're adopting more unhealthy habits, right? Increasing rates of obesity, fast food out, potentially smoking, having high rates of diabetes. These things all lead to atherosclerosis and then strokes. So the first part of my work in this field was looking at what are the prevalence of these traditional risk factors in young people. Are we seeing this increase that would, help us explain this correlating increased incidence of strokes in young adults? And what we found was kind of underwhelming. So of course, obesity, as we know, is increasing. And this is not just for young people, but for older adults as well in America. We did find declining rates of smoking. So a lot of public health campaigns have done a really good job, and we're seeing smoking go down, incidence go down in young people. Hyperlipidemia went down, and this is going to be surprising to many of you. And the reason is because if you remember in the 90s or early 2000, we got rid of trans fat. Turns out trans fat was terrible for LDL. So when that happened, we actually saw a decline as well in the rates of cholesterolemia. And thus far, we have really not noticed tremendously increasing rates of hypertension or diabetes. So those have stayed pretty steady. And then this really did not support the observation that we had made worldwide, where increasing rates of strokes in young people. So second part of our work, we examined a large commercial database. So most young people are employed, which means that they have insurance through their employer. So we looked at one insurance database and we just said, oh, how many of people had their first time stroke? And we divide that by age group. We also looked similarly at heart attacks in the same population. You'll notice that is interesting is that more women, so between the ages of 25 to 45 years old, we notice that more women have strokes. This is kind of in contrast to heart attacks. We're seeing almost twice as many men in this age group having heart attacks. This is really an interesting and unexpected finding. And the reason for that is if you think about strokes and heart attacks, they're generally informed by the same traditional risk factors, right? Hypertension, diabetes, high cholesterol. But why then are more women having strokes? Meanwhile, we're seeing more men, which is kind of what we expected, who have these traditional risk factors develop heart attacks. So this kind of clued us in that there might be something else, especially among young women, that is really promoting them to develop strokes in this age group. So our next big study was we took a similarly commercial insurance all state player database. So all the people in the state of Colorado who had health insurance, and we looked at how much of the risk factors can we attribute to the strokes that are happening? And we divided this up in the youngest age group to the left, middle 35 to 45, and then the older young adult age group 45 to 55 on the right here. And so the blue bar here is all the risks that we can explain. So these include all the risk factors that we can find: high blood pressure, diabetes, autoimmune disease, anything that we can think of, we put in there, and we compared, see how much of that, of the percentage of strokes that we can explain. And then overlapping the green bar are actually the risk factors that we don't traditionally think of as risk factors for stroke. So things include things like migraine headaches, like having a history of DVTs, having autoimmune disease. And what you would notice that's interesting is that among the younger adults, so the 18 to 34, a lot, like more of the non-traditional risk factors are explaining our stroke risk than compared to our more traditional 45 to 55-year-old adult group, where we're seeing more of the traditional risk factors coming into play. The next thing that we did, which we didn't really expect, was to look at how much of this non-traditional risk is explained by migraines. And you'll see quite shockingly here that, and this is almost half of the risk, right? In women who are 18 to 34, we can almost attribute to one single risk factor, which is quite unexpected. So what was interesting about this research is that for a long time, we've known that migraine headaches have been associated with development of ischemic strokes, not just in young women and not just in all adults, but we really hadn't anticipated how much of the risk that one single risk factor like migraines can play. And that was kind of the thing that took us by surprise. So next you'll want to know, well, why do migraines cause strokes? And there are a lot of theories. So as part of the paper, we did a thorough literature search, and we classified all the different risk factors that contribute to why migraine might cause a stroke. And some of these aren't surprising. So PFOs, we know for a long time, are associated with migraine headaches and also associated with ischemic strokes. Some are a little bit disturbing. So potentially some of the medicines that we're using to treat the migraines can also put patients at high risk of strokes. But what was the unanimous answer to kind of our literature search is generally we actually don't know for sure why migraines cause strokes in adults. And the reason is because many of these things they have interconnections and often play along with each other, right? There's a lot of confounding that's going on. But perhaps a better question is, like, why have we not figured this out already? So since about 2006, when this big paper came out with the Women's Health Study, linking strokes and migraines together, we really haven't made that much headway, right? So there's been a lot of theories. And the question really is, well, that's great. We have a lot of hypotheses to test, but why is it that we haven't made that much progress in this area such that we could be trialing new therapies, right? With new guidelines, telling people not to use certain medications, for example, when they have a migraine. And the reason is probably because, one, this is a very complicated question, but two, we really haven't been looking at the right data. And this kind of comes from where migraines sit historically, right? You don't think of this as a cardiovascular risk factor. And so unfortunately, a lot of our really great cardiovascular cohorts, like with GARDs and, all these phenomenal population-based epidemiological studies really haven't collected good data on migraine headaches. And so I think that this area, and part of the reason that we haven't had better answers to how do we address this question of migraine headaches in women and general and anybody really, is because we really don't have the data that we need to inform which of these pathways are perhaps the prevailing pathways. Where's most of this risk coming from? What are the things that we should be looking for? And what are the things that we can do to address the stroke risk in someone who is a migrainer? So that's kind of where we are today.
Thank you, Dr. Leppert. The Go Red Fund has given a lot of thought to this complex patient journey for migraine sufferers. Regardless of age of onset, it usually initiates with multiple encounters across the medical system, whether using the emergency department, being referred to an optician for an eye exam, or even chiropractors. Migraineurs try over-the-counter meds with limited effectiveness that can affect both their work and family life. Once diagnosed, the monitoring and care of these patients also varies depending on their life stage. Recognizing that migraines can start early in the teenage years, young patients may be under the care of pediatricians. Migraine can initiate or is often exacerbated during pregnancy when women are under the care of OBGYNs. And later in life, migraines can also be triggered by perimenopause or menopause symptoms when women are being seen in primary care settings. Can each of you speak to the fact that patients see different providers at each of these stages, and how we think about where the medical home is and how that will impact screening, diagnosis, and prevention for stroke risk? Let's start with Dr. Leppert.
Yes, I think that's a very interesting observation, a great question. And I feel like what also informs the care for the patient is that very different care is provided by each of these specialties. So the focus of the neurologist is going to probably be different from the focus of the chiropractor or a pain specialist, right? So like when the patient comes into my clinic for headaches, like my focus, as well as trying to get the headaches under control, is also to assess them for the risk of stroke, like questioning if a young woman is on oral contraceptives that contain estrogen, and other risk factors like that. And I think that that's something that we do well as a neurologist, but then there are issues where we give a lot of medication to try to prevent headaches, and especially in young people, that we don't do as well because potentially, other kind of more holistic therapies are helpful, like acupuncture or massage or Botox, that, treatments that other providers can perform. So I would say that it would be great if somehow we had a more coordinated effort so that we can work more collaboratively, because I think that right now the care is very siloed. It kind of depends on what provider you happen to see first, and then you're in a pathway that potentially doesn't involve all the other specialties.
Madeleine, any further thoughts on the question of the medical home?
Absolutely aligned. I think, different types of care in different settings is exactly what we see in our own data. I think in the ideal world, primary care should be coordinating patients being referred into specialty care and then having all of that data live within their ecosystem, within the EMR. In the non-perfect world, which is the one that we live in, oftentimes patients are going to virtual clinics because that is what they have available to them. And so the onus is actually on these virtual clinic models to work in such a way that they can pass data compliantly back and forth between primary care providers. So that's sort of where we see model moving, so that patients don't have to be their own medical home. They are able to rely on their clinicians that practice and that serve to meet their needs. And they're able to capture that data so we have a comprehensive picture of a patient's health.
Great, thank you. Migraine is a big market, right? It doesn't suffer from some of the niche women's health fate when we think about it from the perspective of investors. So Maddie, can you speak to why interventions, and whether that's new care models, drugs, devices, have struggled to scale? What do you think are the roadblocks? Is it evidence, awareness, reimbursement?
Yes, we are in the situation where actually all of those are challenges. I'll specifically focus on awareness and distribution. One of the biggest challenges in the migraine space is the process of diagnosis. I think you illustrate very critically here that it's a lot of back and forth. It can take many years. That diagnosis process in and of itself actually hinders the downstream therapeutics market development for new and interesting drugs and med devices to come to market for migraine. The harder it is to get a diagnosis, the harder it is to show that you have a big market such that you want to go and do the R&D undertaking that's going to take to bring drugs to market. So that's part of the issue. And then on the side of distribution, we talked about how there are many different care providers that the patient can come into. What we really see is that it's oftentimes the OBGYN who actually could be at the forefront of making diagnoses here. Migraine tends to arise at a woman's first period. It can be exacerbated in pregnancy, but it's very hard to fit in a migraine screener into an already very compressed clinical visit where there are many other risk factors to cover. And so that availability of clinicians, and that is beyond the fact that most patients are fine, they don't have access to a headache specialist in their area. And so there's both this dual availability of providers' time, but then also actually access to specialists as well, in addition to the broader awareness issue that I mentioned up front. I would also say that we've talked about this kind of in the process of discussing migraine as a critical women's health issue. Women tend to be used to shouldering a lot of pain. And so that awareness issue in terms of the diagnosis process also trickles down to the patient process. People think that it is just a headache. And so they tend to kind of take that pain on and they don't actually press further. And so some of what we really need to see in the migraine space is giving credence to the fact that this is an incredibly disabling condition. It's the #2 cause of disability worldwide. And so being able to tell that story so that patients know that they don't need to suffer. There are options, and they should be coming into care is a really important part of bringing migraine options to patients.
Thank you. That's great. Dr. Leppert, what gaps exist in current stroke screening guidelines for younger populations, and how might data or additional research help to close them?
So unfortunately, I feel like in the young adult stroke space, there is a lack of clarity in terms of what we should be doing. In fact, there are very few interventions that we know are actually helpful for preventing strokes. The only one we currently have is PFO closure if you had a current stroke. And I would say that, kind of building on what Maddie is pointing out, is that a lot of times we're not taking migraine as a serious vascular risk factor, right? So unlike, hypertension or diabetes, or high cholesterol, which we're very used to treating and addressing. If, sometimes if a patient comes in and tells you they have really bad migraines and aura, there really isn't kind of an afterthought, right? Like we're not really approaching them as serious vascular risk factors. And I think that that's kind of the one of the impediments to research in this area is that because we haven't known about how large a risk in terms of our overall burden of strokes in this population is, that migraine has contributed. We really haven't let it, investigated it as seriously as would have something like hypertension and those kind of risk factors that we know that are major players. I think there's a ton of room because we don't even know if having more migraines and if migraines with aura, like, are those like having more of those episodes, does that mean you're going to have a stroke? One of the things that, after we published our last paper, a lot of patients and families reach out to me, which I haven't with my previous publications. And they were like, well, what do I do? What do I do? I have a migraine, have migraines with aura. It's happening all the time. Like, what can I do? And I think that's very deflating as a clinician when patients are coming to you, they're identifying a risk factor, and you don't know what to do about it. And unfortunately, I think that's the position that we're in right now. The best advice we have, which is generally not even a guideline, is risk factors, including like, when you have a migraine, your traditional risk factors actually multiplicatively increase your risk of stroke. So, you don't just add up the migraine risk plus the smoking risk in terms of like the likelihood of developing a stroke, like that risk multiplies. So one thing that we do tell patients is that if you do have a migraine, it's very important that you control all your other risk factors that are modifiable. I do believe in the bottom of my heart that one day we will find that migraines are a modifiable risk factor, but I just don't think that's a reality right now. And we're just suffering from the lack of data, the lack of maybe motivation to really try to figure out what's going on.
Great, thank you. We've talked about the fact that, neurological care is limited, the access to that, and there are usually long wait times to get to sort of the specialist. Maddie, what does data tell us about the effectiveness of sort of telehealth virtual care options in managing or even diagnosing migraine, and potentially how could that play into screening for stroke risk?
Absolutely. Excellent question. I think one of the most striking things that we see in our data is that the patients that come in to see us upon clinical intake are significantly severe. So 75% of patients are coming in with severe MIDAS scores. MIDAS is the gold standard clinical outcomes metric for migraine. And I find that in telehealth, there tends to be sort of this misconception that telehealth is for low acuity needs. But we can see by the burden of morbidity of the patients that are coming in to seek care, these are really sick patients that have had no other option. So that's been one, compelling component of evidence that I've seen come through our own clinical data. When we benchmark our clinical data against clinical trials for CGRPs, we see the same or more effective outcomes in terms of reducing headache frequency and severity. So that's also been incredibly encouraging. And that type of data that we've been rigorously committed to collecting has enabled us to go out and sign some of the largest relationships with payers to essentially take our program to their members as a way of promoting access to headache and migraine medicine. On the risk factor screening front, I think much to what Dr. Leppert said, a migraine diagnosis in and of itself is a risk factor screening. And so I think of our patient population, we have many patients that are, in their childbearing years, getting ready to have children. Enabling them to actually go into an OBGYN or a maternal fetal medicine doctor with a migraine diagnosis while pregnant is important. They can then go and manage their risk throughout their pregnancy accordingly. The other aspects that I really see this is beyond migraine medicine, we also have a sexual and reproductive health clinic. Multiple times every single day, I see our clinicians having discussions on what constitutes migraine with aura. And what they're often seeing is that patients are coming in on combined oral contraception pills and they have migraine with aura. And so they immediately need to be counseled to find a more effective option. And so that's another way that we're actually actively working with patients to make sure that they're managing their risk effectively while on migraine. One last example. So one of the really interesting things about telehealth is that it enables highly protocolized care. So, for example, we can't forget to take a blood pressure reading. And so we also have several anecdotal examples of patients who have come in, they have abnormal hypertension readings, and then we're actually able to flag that and go and, divert them to critical care, divert them to the attention that they need from their clinicians. So those are a few examples of how we're doing both the prevention and the risk factor screening, as well as seeing really excellent data from bringing this care model to patients.
Yeah, and that is a great segue to my next set of questions, which is really around the enormous data gap that we have in migraine and how that impacts research and clinical care advancements. Many studies, and Dr. Leppert, you did speak to this during your session, that use claims data, which is intermittent, siloed, and often difficult to access. When you look at the other end of the spectrum, we have wearables becoming more popular, and they track and monitor sleep and heart rate and other factors from sort of the real world side. However, I do know that Many feel consumer data falls short of the caliber desired for research, and also not always easily accessible. So I'm curious to hear from both of you. Do you have concerns about kind of patient-reported data or collected data around triggers like diet and stress? And if so, or if not, talk about how it can be valuable in advancing the field. Dr. Leppert, can you start us off?
Yeah, sure. And this is something that I thought a lot about. And I really thought when I started, in this kind of research career like 10 years ago, that I was going to find all my answers in the claims data set, right? Like, because the answers are already out there, it's in the EHR. I just have to look harder, build better models. And it's come like to my realization after a decade that this data actually doesn't exist yet. And I think it's a combination of factors, like you mentioned, Tracy. I think some of it is like we have to ask the patient specifically, right? Especially for a risk factor like migraine. Like, what is your migraine frequency? What is the triggers that help your like develop, your migraines? What kind of aura do you have, right? Or how often are you having these auras? And these aren't questions that are being asked. And so frequently they're not in the EHR. They're not data that exist and are available to us. And I think that the other thing is we're also not looking at the factors that are associated with migraines and with strokes, right? Some of these confounders, including having a PFO. So, and it's not clinical practice. So really, outside the realm of research, we wouldn't be screening patients for having a patent foraminal valley, which is, highly associated with migraines and also a risk factor for a stroke. So I think that there is obviously a lot of opportunity for us to integrate the data. And I think that like I'm now learning and coming into the realm of the patient kind of collected data. And I do think that it is very important. And I do feel like there is a role for that and somehow integrating that with our albeit EHR or other data sources where we can kind of have a very reliable data collection. Because I think that the way that we traditionally do this research is send a nurse in someone's house, right? And they would like collect all this data. They would measure all the blood pressure and do all the tests. But I think that those kind of studies are really falling out of favor because they're just so expensive. And they may not even collect information in they have the depth information, but not like the amount of information and the large population that we would need. So I'm really all ears for better ways to get the data we need to really answer the questions about how we can treat people better with a migraine as a risk factor and how we can use that to mitigate their future risk of stroke.
Maddie, do you want to speak to it as well from the industry side?
Yeah, absolutely. I think I'll take a consumer approach and then I'll throw in an industry approach. From a consumer approach, this is a condition where people feel no agency. They feel completely as if the migraines are out of their control. And so if they are using data that enables them to feel like they can better pattern recognition and track, then please use data and please use that to feel like you have more agency over your ability to anticipate migraines. So that's kind of my take from the consumer side. From the industry side, in terms of claims data and then all of these other different types of data, I think the perspective is that these data are always more interesting when they're kind of overlapping and you can analyze them together as one. So for example, we can look at claims data matched into all of the patient reported data that we are collecting in a de-identified and aggregated way. So patient reported data includes things like healthcare resource utilization. You see that definitively in the claims data, but then we actually go and we'll ask, how many times have you been to the emergency room? Why did you go to the emergency room? How many times did you seek imaging? And so combining these data together kind of enables you to ask and surface questions that you have not been able to answer previously. So we are in general very pro trying to find ways to bring together different sources of data and making meaning out of all of that information, especially since we know the claims data is very imperfect here. So many different codes that can kind of roll up into migraine that are not necessarily captured, which then leads to essentially employers who are downstream of payers who have the claims data, not really recognizing how much of an issue migraine is. And so we actually need multiple data sources to tell the accurate picture to all of the stakeholders here.
Great, thank you. Getting a few questions from the audience, which is great. So I want to encourage folks to use the Q&A. Let's start with this one. Migraines around the menstrual cycles, right? We've talked a bit about the life cycles, but curious if there's a hypothesis around hormonal cycles and whether they could present a higher time of risk for stroke, or are there any ways to take preventative steps around menstruation that would, give patients or even providers some guidance on how to do this? Dr. Leppert, any thoughts?
Yeah, I think that's a good question. And absolutely. So in women, a lot of migraines are associated with the menstrual cycle, and generally right before the menstrual cycle occurs, called catamenial migraines. And so like kind of in our research that we come across, a lot of OB-GYNs believe this may be because of a estrogen withdrawal period. And how this informs the risk of whether or not you're at higher risk during this kind of period for a stroke, I'm not sure. I don't know that. I think that would be a really interesting question as a research question. But the other thing we don't ask, right? Because I never, and this is maybe my fault. I've never asked the patient when they were in the hospital for a stroke, like, oh, are you on your cycle right now? Like, that's actually not in the medical record anywhere, right? Because if you think about it, like, so I think that's a really interesting research question that potentially, like, with some more data we could answer. But to be honest, I don't know that anyone's ever looked at this before.
Yeah, super interesting. So Maddie mentioned awareness and women thinking migraine is just a headache, right? So in women's health, we've seen the cultural conversation change, right, relating to women's health. Oprah, Michelle Obama talking about menopause. And are there conversations happening culturally that are changing the migraine conversation and facilitating a more of an opportunity here? Maddie, you want to take that first?
Yes, absolutely. So I've been thinking about this for a while. How do we bring the needed attention to this space? So one example is in the area of endometriosis, which many of us are familiar, and migraine actually can also make you more likely to have endometriosis, just to throw that out. There was a documentary pulled together called Below the Belt. I would love to see something similar for migraine. They were able to build significant awareness around endometriosis that way. They, again, similar to some of the conversations that we've had, they brought in celebrities to support the rollout of this film and to do more documentary education. I think that would be a really interesting area to start. There's also been a ton of momentum around menopause. People are talking about menopause now than more than ever. This could be an area to start bringing in migraine. I think we need to take every channel that we can to try to drive education around this topic. And the more we drive education around this topic in the cultural conversations, the more likely it is that a patient will walk into their primary care visit, walk into their OBGYN visit and say, I have migraine. And they'll be more likely to flag this as a risk factor to their clinician, who hopefully has the education to know to treat this like a risk factor and to navigate them to the right form of care.
Dr. Leppert, do you have anything you'd like to add?
Yeah, I absolutely agree with what Maddie said. I think that it's almost like a culture. I feel like we just started with this belief that migraines were this very benign phenomenon. We tend to kind of write it off, ignore it. But it turns out a lot of people with migraines also have these silent strokes that you can see on their MRI. So even those that don't show up for to the hospital with focal neurological symptoms that we can diagnose as a stroke, we're finding that they have like lesions on their MRI that we can see that for a long time, like even as I was training, we've just written off. It was just like, oh, something that you can see with migraines. And we kind of gave this hand wave. And so I think that hopefully the culture change is coming where we're starting to recognize like, yes, this is a migraine is a phenotype for a vascular risk factor. And until we can kind of give it that respect that it's due and even collect it, you know, in the chart of the patient as a risk factor so that people like me can go back and look at the data and really characterize, you know, how much risk that migraine pose. I think until we're there, I feel like it's going to be hard for us to give the, you know, the credibility that it deserves.
We are getting a lot of great questions, so I'm super excited. Let's go into the next one. So, more of a, you know, we'd love more data. We'd love to sort of have better insights into how, you know, these symptoms are manifesting, triggers. How do we encourage patients to track this information without creating additional anxiety, without sort of data fatigue, right? Because the risk of stroke obviously is a stressful factor to lay on patients, but we need the information to help us develop solutions. So maybe I'll start with Dr. Lepper, but have you both speak to, you know, what are your thoughts here on how we create encouragement without sort of fear and anxiety?
Yeah, and I think the talk I frequently give patients with migraines and with PFOs is like, you're not a ticking time bomb. Like I don't want them to go around thinking that they're going to have a stroke at any moment, right? The absolute risk of having a stroke because you have migraines or because you have PFOs is still fairly low. Especially for younger people, right? So I think that we need to kind of put that in perspective that, you know, they're not just even if you have a PFO, you have migraine with aura, like you're not just, you know, walking around, you're going to have a stroke any second. That's certainly not the reality. But at the same time, I do find even if I'm just trying to get your migraines under control, it is very helpful when patients can come in, they can tell me like, kind of when the migraines occurred and do keep a journal so that we can kind of objectively keep track of if our treatments interventions are working. So I do encourage them to use now with our technology, things like the migraine tracker apps that I do find are helpful. And then they do provide some feedback, I believe, on like the frequency of migraines and potentially potential triggers as well. But I am not super familiar with other ways to kind of log and track the migraines.
Maddie, can you give us, obviously you see a lot of data collection, speak a little bit to some of the options out there or how you see us encouraging disclosure without creating fear?
Yeah, absolutely. So we have a migraine tracker that's incorporated into the Cove experience. And it's an interesting human design challenge because also in the midst of a migraine attack, the last thing that you want to do is encourage someone to be sort of like actively logging things into an app. And so a lot of times the counseling that we give is, you know, do it retrospectively if you can. There's a little bit of recall bias there, but we want, you know, if it is helpful to a patient to do tracking, we want to encourage that. I would generally say though that it's the education here that is important. I mean, there's lots of studies that look at the use of wearable data and how that helps encourage behavior change. I think even having that conversation with a trusted clinician where again you give credence to the fact that it's not normal to be in this amount of pain and that this is a chronic condition, it sort of reinforces the fact that you should take your own health seriously. And you know, maybe in turn that means that you think about some of those other risk factors for cardiovascular disease that are within your control and you treat those more seriously.
That's a great lead in to one of the questions here. In addition to not smoking during migraine with aura and periods, are there other risk factors that are sort of easily recommended to patients to help address some of these symptoms? Dr. Leppert?
Yeah, I think that some people think that there's a lot of overlap in terms of lifestyle changes when you have a migraine. So there's a belief that some migraineurs will smoke more or become more dehydrated, hence making them more hypercoagulable. I'm not quite sure how much credence to give these theories because I don't know that we have the data to support it. Kind of like the way we thought, oh, young people must be very unhealthy and that's why we're seeing more strokes, right? I hate to kind of assert that, there's some lifestyle change that migraines are doing and therefore the stroke is secondary. I think that in general, my recommendation is if you have migraine, especially with migraines with aura, that controlling your other risk factors is very important because that they can really multiplicatively increase your risk of stroke. So things like high blood pressure, high cholesterol, diabetes are very important to have under control, kind of especially if you have migraines.
And then, can you speak, either of you, to research on, especially migraines with aura, on triggers that are not related to hormones? So heat, exercise, light, and in that context, recommendations and how we take steps to improve the data tracking in the space. Dr. Leppert, you want to start, and then we'll ask Maddie?
Sure. Yeah. And to be honest, I don't know that we have the answers. There are certainly like lots of triggers for migraine headaches, like red wine, cheese, kind of the traditional lack of sleep, right? Dehydration, the things that we know. But I feel like, to be honest, I'm not sure that we have looked at the data and scrutinized the data very intimately to really understand why these triggers are, are like lead to migraines, and if that also subsequently will increase your cardiovascular risk, or is it just, whereas the migraine is kind of the phenotype that occurs, and it was really like, the smoking and things like that that would have led to the stroke in the first place. So I think that we're suffering from a lack of answers in this field, unfortunately.
I agree. Madeline, further thoughts on that one?
I think the inclusion of non-traditional data sources that Dr. Leppert and I talked about earlier outside of claims data is going to be really interesting here, just given the fact that we do have so many unanswered questions. I would love to see, if you're out there listening, Whoop or Aura Ring, think about taking on migraine as an area to do more research. I think on the industry side, which we talked about earlier, there are so many different ways that you can start to think about bringing non-traditional data in to create better devices, to create better therapeutics. Everything from early biomarker discovery down to trial participation, down to post-marketing studies of how these drugs and devices actually operate in the real world, through to we now have things like digital therapeutics. So actually using apps for patients to improve their migraine symptoms. We're starting to see these come to life. I think it's just about getting dedicated support and funding to actually studying this information. Again, I was delighted to see that the American Headache Society and the American Heart Association actually have pulled together an opportunity to support researchers in the intersection of these two condition areas, because we desperately need funding and we desperately need more research.
Yeah. And then let's talk a little bit about the genetic side, right? Are there genotype first approaches shaping the future of personalized migraine treatments? Dr. Leppert?
I hope so. So I think that there are like a very small subset of headaches that does lead to strokes, right? Like we're thinking like carousels, disease, things that like mitochondrial diseases that are also linked with migraines and strokes. So there's absolutely, I think, an intersection between like the genetics that put you at higher risk of both conditions. I think that and I don't know, I'm not aware of any studies currently, but I think that definitely would be really interesting to look at is the genotype of migraines and potentially what types of genotypes of those that are associated with migraines also put you at higher risk of cardiovascular disease. And we absolutely know that migraines are familial, right? Because one of the questions I ask my patients is who in your family has migraines? And inevitably, the answer is not no one. It's always somebody. And so I think that we know that there is a highly genetic component to migraines. I'm just not sure that we know how they intersect in terms of cardiovascular risk playing into that.
Great. Thank you. I'm going to shift a bit now to sort of providers and care delivery. And so I'd love for both of you to share thoughts on how we educate providers about migraine being a risk factor and how therefore sort of educate ourselves as patients, right? So let's start with the providers' thoughts on, given we talked about these sort of different medical homes, how do we spread the word? What is the most efficient way to help bring care delivery and providers along in this journey with us? Dr. Leppert, do you want to go first?
Sure. I'm not sure what the answer is because I do think this is my personal soapbox. Kind of that migraine's a serious vascular risk factor, and we take it more seriously, especially like as a young stroke neurologist. And I feel like at some point the culture needs to change, and maybe through some of the avenues that Maddie had mentioned previously, where either through funding or through like culture changes. I think that we're starting to look at migraines differently, because I do think that there's a very entrenched, longstanding idea that migraines are this very benign, don't worry about it, go tough it out kind of philosophy. So I do find that is something that I have to get through as well.
And Madeleine, other thoughts?
I think we need to just keep showing up where many of these providers who are on the front lines are. ACOG is a great example. Migraine experts need to be at ACOG, need to be in front of OBGYNs who, again, are seeing many of these patients who have migraine arise as part of their period. We need to be in the places where we can educate other clinicians who are also on the front lines of migraine, like the emergency department clinician. So many of us in the migraine space know that these patients are frequently in the emergency room, frequently in urgent cares. And so getting in front of those clinicians and figuring out how to give them effective, easy screeners like the ID migraine screener, which is 3 questions, or referral pathways to get to seeing a neurologist or an expert in headache medicine and migraine are going to be the ways to continue to make change incrementally.
Yeah, we agree. On a positive note, and maybe Maddie, I'll start with you. Have you seen any products, clinical trials for either drugs or devices that are more geared towards this younger population, or sort of how are we seeing on the horizon opportunities to both engage and support these patients from either a med device or a pharmaceutical perspective?
Yes, absolutely. I think on the industry side, there's now some effective work going on in the menstrual migraine space. So there's a clinical trial in the menstrual migraine space that's occurring right now. We also have researchers who, like Dr. Leppert, are extremely educated in both the fields of cardiovascular medicine, but also in the fields of headache medicine. So there's a doctor out of the Mayo Clinic, Dr. Chang. She is specifically focused on using AI tools to actually go through and read cardiovascular health reports and then be able to map that back to migraine patient registry. And so she is right now using AI to be on the forefront of what are some of these early warning signs that a patient that has migraine is maybe more likely to go on to experience a sort of major adverse cardiovascular event. And so I think the more that we can fund those researchers who are taking those innovative approaches of using AI tooling to actually do this cross comparison of patients with migraine and then patients who also have gone through and who have had cardiovascular readings, we can start to surface that there might actually be some early signals that these are patients who are deteriorating and that we need to pay closer attention to.
Great. Dr. Leppert, any thoughts, or what are you seeing either on the preclinical or clinical side for these opportunities?
Yeah, I agree with Maddie. I feel like they're like I think getting out there with other providers, and I kind of second my first point, which is unfortunately we're really siloed, right, as providers. I do think the International Stroke Conference is one of the most collaborative conferences I've been to because it's not just a conference for neurologists, right? But I feel like as providers, we're often broken into our specialty, like our board specialty. So like I know lots of neurologists, I don't know many OB-GYNs, right? And I think that's kind of the barriers that we face is that culturally we're really stuck in our own specialty and that we're not talking to people like Maddie or going to OB-GYN conferences and really providers that, even emergency room conferences, like providers that also touch the patients that we see, right? And I don't think that's generally in the best interest of the patient. And I wonder if we just had more of these conversations, like, and really thought about the problem from a different perspective, like we would come up also with better solutions.
Agreed. I'd like to also maybe go back to talking a little bit about sort of the innovation side. I always want to end these opportunities on sort of an up note. But as we think about developments in this space, what do either of you, and I'll ask you one at a time, but see as the real opportunity to bring together the players in this journey and for patients, as well as sort of the information/data piece. So, Maddie, I'll start with you, but sort of what's the big grand idea here that you can think about?
My vision would be that we have a prevention playbook and we're doing primary prevention. We're finding patients before they're even experiencing any of these cardiovascular events as a function of having migraine. And we're enabling providers to action that preventative playbook. So I think that's the grand vision that I would be working towards. And then my role in general is focused on now how do we bring in the payers? How do we bring in the employers and show them that there's real economic value to giving patients the care that they deserve? And so I would love to have that preventative playbook backed by data, backed by evidence that is built out, based off of research that is created so that I can then go into employers and payers and make sure every single person in the country can access this for free. I think the goal ultimately is getting care for patients that does not cost them anything, because we know that that will be more likely that patients will actually go and utilize that care. But it's also, in women's health, we oftentimes face this reimbursement issue where services that are generally associated with women's health are reimbursed at lower rates. And so my goal would be we get that preventative playbook live, we get it to patients, and it's reimbursed at a rate that is fair and that represents the incredibly hard work that providers are doing every day to meet patients where they are across the country.
That's great. Dr. Leppert, your thoughts?
So my dream would be that one day migraines become a modifiable risk factor, right? So like I have a patient who has migraines, but either as primary or secondary prevention, I can offer them things that they can do to modify this risk. Like maybe it's, certain types of abortive medications. Maybe it's like trying to reduce their risk around their menstrual cycle. Maybe it's closing a PFO. So my dream is one day that we can actually address migraine as a risk factor, similarly to other kind of known vascular risk factors.
Yeah, I love that vision. Well, we have covered a lot of ground today with valuable insights from our panelists. So I want to thank Dr. Leppert and Madeleine Livingston for sharing those insights. We've given some thought here to sort of what we think the future of innovation can look like, right? And this is not comprehensive, but just a few takeaways for our audience to think about as we try to move this field forward and bring together solutions for patients, right? So we've talked about platforms level leveraging either mobile or wearables, and both for risk monitoring and new care models, integrating, early risk screening, especially for our younger populations. I think, talking about guideline development and how we start to serve these diverse and underserved patients better. digital platforms expanding access. We've touched on that, and I think, really see potential here to complement the existing infrastructure for clinical care. And yes, our hope is there are some next-gen therapeutics out there and inclusive trials to make sure that we have kind of innovative solutions, whether on the therapeutics or non-pharmaceutical side. So from our perspective, this is a tremendously large market opportunity with great opportunity for investment. And we certainly encourage our listeners to think about the role they can play in catalyzing this field further. So again, thank you to our panelists. Everyone, we would like to encourage you to join our list so that you can participate in future conversations like this. Please scan the QR code to join. We'd love to hear more from you. And if you have questions following, please let us know. Our recording will be available in the next week, and we invite you to join us in February for our next webinar, which will focus on autoimmune conditions and their implications for cardiovascular and stroke risk. So thank you, everybody. Have a great day.